Hi, my name is Bill Borden, and I'm a cardiologist at George Washington University, and I'm chair of the Quality of Care and Outcomes Research Council in the AHA. And I'm here today with Dr. Sandeep Das, who's a cardiologist at UT Southwestern, who's participated in a panel that we had recently at the completed AHA Q-Core Scientific Sessions, which was held virtually, in a session that was entitled Cardiac Implications of Non-Cardiac Disease. We had other excellent presentations, including on the opioid crisis and infectious endocarditis, and then discussed what's on so many of our minds, which is COVID-19. And to that end, Dr. Das and his colleagues have launched a phenomenal new registry within the AHA called the COVID-19 Cardiovascular Disease Registry. And so Dr. Das, thank you for being here. And I was wondering if you could just start and talk about how you and your colleagues came up with the idea for this registry.
Thanks for having me. So as you're well aware, COVID-19 is the public health crisis of our lifetimes. And it's associated with incredibly high case infection rates and over 80,000 dead at this point. We have a pre-existing group within the AHA Q-Core group that looked at trying to figure out better ways to address and implement quality improvement initiatives. So when the COVID pandemic really started to flare up, it was a natural connection to sort of leverage the group that we had to try to address issues related to how to understand and better treat this public health catastrophe.
Great. Well, that's wonderful and incredibly timely and responsive to the needs. And you and your colleagues were really able to stand up this registry in an incredibly short period of time. I was wondering if you could talk a little bit about the process going from idea generation to having a live registry.
Yeah, it's kind of startling to me even to think about how quickly things have happened. You know, a lot of this is the credit of my co-chair, James DeLemus, and to our steering committee, Steve Bradley from Minneapolis Heart, Dave Morrow from the Brigham, Mitch Elkind, next president of the AHA from Columbia, Fatima Rodriguez from Stanford, and Tracy Wong, who's probably well known to this audience from DCRI. This is a stellar group of people, and the AHA staff has been phenomenal. Mariel Jessup has led that effort. And we've worked together and stood up the registry from nothing to an existing skeleton of a registry within probably 10 days. And then now that we are about a month or so into it, we have an existing registry with about 1,000 patients entered in it and about 50 participating centers. So it's been just a huge testament to the effort of the people at the AHA and my fellow members of the steering committee.
Wow, that's amazing progress, and certainly a wonderful group of experts to bring together for this registry who certainly understand clinical registries, and then just really amazing enrollment. What sort of data fields, what sort of data are you capturing in the registry?
So the two major shortcomings, I think, of existing data that we see related to COVID-19 is that a lot of it is unselected data, unselected laboratory data, things like that, where people are tested basically out of clinical suspicion. And then on top of that, there is a delay innate to some of these registries where it just takes months and years to move things through various layers of like RMP committees, et cetera. So I think the two really novel aspects of this registry are, number one, that we are looking to collect systematically from sites, including biomarkers, serial biomarker data in all patients with COVID-19. So what that means is it'll allow us to better draw inferences. So we won't just have lab values in the sickest of the sick patients. Rather, we'll have lab values in the full spectrum of patients, which will allow us then to correlate some of these biomarker change patterns to clinical change, et cetera. And then the second thing is this model for burst science. So This is a really revolutionary procedural aspect of this registry, which is we're going to leverage the American Heart Association's precision medicine platform. The data are going to be available, and then centers can bring their own statistical expertise, submit a proposal. If the proposal is approved, they will get a version of the data set that they can work on at their own centers and do the analyses there. So traditionally, as you're well aware, a lot of these large registries, the analyses are rate limited by how many the Central Analytics Center can do. And our Central Analytics Center is the DCRI, and they're fantastic. But the challenge is there's just a throughput problem with how many large studies they could do in an amount of time. And we really felt keenly that the need to get these data out there as fast as possible because of the pressing nature of the pandemic. And so what this will allow us to do is leverage the individual investigators at the individual sites, local expertise, and let them do the analyses in a distributed fashion. So really that's kind of a groundbreaking effort with this registry. And I'm really excited to be a part of that.
Yeah. Well, that's wonderful data that you're collecting and a really cutting edge approach to clinical registry data, which I think is going to not only help in this COVID-19 era, but hopefully advance the science of registries and how we approach this research in general. What are some of the initial research questions that either you, colleagues, or others are looking at, or that you think the registry has the potential to answer?
I think that the initial slate of studies that come out of this are going to be descriptive and observational. Race and ethnic disparities in outcomes for COVID have gotten a lot of attention recently. And, I think that we will definitely explore that in detail. There are a lot of very fascinating biomarker patterns associated with a more severe COVID-19. And I think that that's another natural place to look. In terms of therapeutics, we're collecting information on all the various therapies that people are getting. But one that I think is probably top of the list in terms of deserving analysis is patterns of anticoagulation. So we know that COVID-19 is associated with a lot of thromboembolic complications, and really looking at how different institutions approach their anticoagulation issues and how that may then convey to patient outcomes, I think will be super important. As you know, it's really difficult to do straight outcomes research out of these large registries because it's observational data. So we're working hard to, both on the analytical side and on the data collection side, really try to account for some of the potential shortcomings and to really have a very comprehensive and thorough data set here.
Mm-hmm. That's great. And you mentioned the ability to access these data and some of this cutting edge technology. So as a researcher, how do I get plugged in? I have a research question. How do I access and start using this registry?
So fantastic. What will happen, and I expect you to submit something, Bill. What will happen within probably the next several weeks, there'll be a formal call for proposals, maybe as soon as June 1st. And then when that goes out, there's a form that we've created that people can submit. And one thing that's a little different from a lot of traditional registry forms is that we are going to ask the investigators up front to come up with a more detailed analytic plan. And part of that is because we're going to count on the sites to do, if they elect to do that. So they're going to have three choices. They can ask to have their work done at the DCRI. They can do the sites locally with collaboration with data scientists from the American Heart Association, or they can do the studies locally with their own local expertise. And because of the latter option, we're really going to call on people to come up with a very relatively detailed statistical plan. So that's going to be the key difference between this and other proposals that are out there. And then the other side to it is we want to have, as we go forward, we'd love to have actually just a real-time rolling evaluation of these proposals rather than saying once every 6 months, once every 3 months. That timeline just isn't going to cut it here. Initially, there probably will be a de facto batch just because of the fact that we're going to call for proposals and there's probably going to be a bunch that come in the very beginning. But over time, we're going to streamline that out, I think, a little bit and have it be rolling submissions. So when you have an idea, you can submit it, we'll evaluate it. And if you're going to do it locally, then when we approve it, really all we have to do is to look at the science, and is this a legitimate way to answer this question? And if so, we'll get out of your way and let you do it.
Great. Anything else that we should know, Dr. Doss?
Yeah, I think that the key here is that before we actually, got into this, I would have never thought that all this was possible. So I guess the key here is really to leverage the expertise of a lot of people, and get people working together, and sort of, if anything good comes out of this crisis, it's really that people can really pitch in and work together and accomplish amazing things in a very short period of time. That alone, I think, has been a pretty stunning observation for me.
Well, thank you, Dr. Doss, and your colleagues for launching this into the AHA, for putting this together. I think this is really a great example about how the AHA and the Q-Core community within the AHA can really be responsive to real-time, actionable questions, and how we can use the data and the science to improve care as quickly as possible for everyone. So thank you so much. And
thanks for having me.
thanks for the work that you're doing.